I just had a great doctor's appointment with my son Justin, and there was something that surprised me. During our well baby visit, the nurse and the doctor looked into my son's mouth and asked me some questions. I thought it was great, but a little bit surprising just because I had always thought that dentists were the ones who checked out kids' teeth. I did not know how important oral health was for Justin and for my family, and I didn't know that this is where Justin was most at risk for disease. But thanks to this visit and to all of the staff, I know now what to look for in my son's mouth and how to really keep his mouth healthy.
Caries, or dental decay, is a major problem afflicting children in the United States. 4 to 5 million children have severe oral disease, often making eating, talking, and even smiling difficult. The Surgeon General's report, Oral Health in America 2000, states that this is the most common disease in children in this country. If this were any other disease, it would make national headlines, and we would call it an epidemic. Well, it is an epidemic, and it is a disease, a transmissible bacterial disease. However, because it is a bacterial disease, it is preventable. Successful prevention relies on education and observation. If dentists, nurses, and pediatricians, as well as others in the healthcare field, work together, we can substantially reduce early childhood caries.
My name's Dr. Ray Stewart. I'm a pediatric dentist practicing in Salinas, California, where we have a population of children who have a very, very high incidence of early childhood caries. I am going to be demonstrating today an infant oral examination on several patients, commonly and often referred to as the knee-to-knee examination. This examination varies somewhat from the type of evaluation that is done in a pediatrician's office or in a field setting where children are being screened for the presence of early childhood caries or other dental diseases. You'll notice that in the examination we are using gloves because there is direct contact with the infant's oral mucous membranes. And we're using an armamentarium that consists of a toothbrush, oftentimes a mouth mirror, a good and adequate light source, and in some cases a tongue blade and 2x2 gauze squares.
If pediatricians, as part of their well baby checkups, do a simple and quick infant oral risk examination, we will save millions of healthcare dollars and prevent needless pain and anguish in our children.
Although recently we have emphasized the need for the first dental visit in a child to be at about 1 year of age or about the time the first tooth erupts, the practical matter of it is that most children do not see a dentist until quite a bit later in their childhood. It stands then that the pediatrician, the obstetrician, and the family practitioner in medicine who is most likely to see and identify these infants at an early time when there still is a chance of reversing the process or preventing the actual development of dental caries in these children.
Dental decay is a transmissible bacterial infection. Whether or not decay progresses is determined by the balance between several pathological and protective factors. One of the pathological factors is the acid-releasing bacteria Streptococcus mutans. Usually these bacteria were introduced in the child's mouth from a caregiver, most often the mother. We all have some of these bacteria in our mouths. The bacteria ferment carbohydrates and sugars, producing lactic acid, which dissolves the tooth enamel. Other pathological factors besides the amount of the bacteria include the frequency of ingestion of fermentable carbohydrates such as sucrose, fructose, and cooked starch, a lack of fluoride, no sealants, and salivary dysfunction. The protective factors include antibacterial agents, brushing and flossing, infrequent snacking, fluoride, xylitol gum, sealants, and good saliva flow. When the pathologic factors prevail over the protective factors, the tooth is more likely to demineralize, resulting in decay. For example, when an infant gets too much bacteria from a caregiver and then drinks juices all day long in a sippy cup, that child is ripe for early childhood caries and the pain that comes with it. When the protective factors prevail, the decay process is inhibited, sometimes even reversed. In California, we have a serious problem because we have twice the national average of untreated tooth decay. 27% of preschool children have untreated decay, 55% of 6 through 8-year-olds have untreated decay, and up to 75% of Latino high school students have untreated decay. Many millions of dollars are spent each year on the physical treatment of dental caries. However, the epidemic is continuing its course. The way to control it is through thoughtful, collaborative, and efficient prevention.
The doctor sat down knee to knee with me and showed me what problems to look for in Justin's mouth. In about a minute, I learned that bacteria and infection actually do cause cavities, and about how important Justin's mouth is to his overall health.
The infant oral health examination includes a risk assessment in the form of simple yes-no questions as to whether these risk factors are present. Some of the questions are asked before the oral exam, either on paper or in person, determining the potential of the amount of the bacteria in the child, how much of the bacteria is the mother carrying, as well as the frequency of sugar and carbohydrate intake. The questions are: has the mother or primary caregiver had active dental decay in the past 12 months? Does the child sleep with a bottle? Does the bottle contain fluids other than milk or water? Have there been recent dental restorations completed, less than 2 years? Are there frequent, greater than 3 times, between meal snacks of sugars and cooked starch? Then, while doing a simple 1-minute oral exam, the pediatrician or the health practitioner can determine whether the other risk factors, such as the appearance of white spots or gum bleeding, are present. The risk factors are obvious white spots, decalcifications, or obvious decay present in the child's teeth. Child's gums bleed easily and/or plaque is obvious on the teeth. Appliances present, fixed or removable. For example, space maintainers, obturators, etc. Saliva-reducing factors are present, including hyposalivatory medications, that is, some for asthma or hyperactivity, medical cancer treatment or genetic factors. The child has developmental problems.
If there is a positive or affirmative answer to any of the questions, a red flag should go up, and these infants should be considered in the high-risk category for the development of dental caries until proven otherwise. In those communities where dental care is readily available, I would advocate that once these children are identified as being high risk or having the very earliest stages of early childhood caries, that these children be referred to a dentist who is comfortable and used to working with infants, toddlers, and young children.
I was so impressed by the things that I learned in just a minute. I'll be scheduling a visit to the dentist in a few weeks, not because anything's wrong, but by doing this, I know I can help keep my son's mouth healthy.
In many communities, there is difficulty in obtaining access to dental care for the children and the parents who are identified as being in this high-risk categories. In many cases, these families will be in low income, oftentimes on Medicaid, or have no types of dental insurance, and oftentimes no health insurance as well. In instances such as these, I think it's incumbent for the pediatrician or family physician to serve as the first line of defense or the first line of offense in terms of treating these kids.
Also, research and new studies reveal that xylitol gum helps prevent oral disease. If the mother of an infant has a lot of the bacteria, she should chew xylitol gum 4 times a day, inhibiting the bacteria and therefore preventing her from passing too much of the cariogenic or decay-causing bacteria to her child. Another thing we can do is make sure that the child is getting fluoride. If there's not enough access to a dentist for this family, the pediatrician can apply fluoride in the form of fluoride varnish for both the mother and the infant.
Topical fluoride has proven to work and is clearly effective in the prevention of tooth decay and aiding in both tooth remineralization and the reversal of the caries process in the early stages of caries development. It's a great technique for the children because it works, and parents feel that something positive is being done for their child, and they are participating in a clear benefit.
Also, the pediatrician can advocate brushing daily with a fluoride toothpaste for the mom and for older children. Fluoride helps prevent tooth decay by adhering to the microscopic crystals that make up the structure of the tooth. It coats the enamel of the tooth and makes it harder for the acid to penetrate the enamel surface. Fluoride has been shown to reduce the prevalence of tooth decay by as much as 40%.
The American Academy of Pediatric Dentistry and the American Academy of Pediatrics both agree that a child's first dental visit should occur in conjunction with the eruption of the first primary teeth, or at about a year of age. Unfortunately, various barriers and lack of access usually keep the kids most in need from getting to our offices until it is too late. If children are identified through the caries risk management and assessment process and referred to us early enough, we can very often prevent or at least interrupt the caries process at an earlier stage, utilizing a variety of tools, including topical fluoride application. You, as primary health care providers, have the unique opportunity to identify those children at highest risk and to refer them for care much earlier so that together we can truly make a difference in children's lives.
It is through the teamwork between the physician and the dentist and other oral health care professionals that we're going to make some inroads at reducing the magnitude and the intensity of this disease in the children of our country.